Good morning, everyone. Welcome to my channel. And then this is my first presentation. It is a link up and a build up for my WhatsApp page. And today we are going to continue with immobilization device. So let's look at the introduction to this topic. So we'll start with what immobilization is. So immobilization refers to the restriction of movement of a body part to allow healing, reduce pain, prevent further injury, and maintain proper anatomical alignment. And this technique or method is used mostly to manage fractures, joint injuries, deformities such as clubfoot, and some post-operative orthopedic conditions. So the most common immobilizing devices used in orthopedic setting or care include the casts, splints, braces, and orthoses. But in this presentation, we are going to focus our lens on casts. So let's begin with casts. So introduction to cast. So what is a cast? A cast is a rigid circumferential external immobilization device which is molded to the shape of the body part it encloses. So this immobilizing device is being designed to actually accommodate and form a shape around the structure that it covers or encloses. So cast materials. So casts are named or classified based on the material used in making this device, which is the cast. So you have the plaster of Paris, which is the POP. So that will give you a plaster cast. Then we have the fiberglass or polyester, which will give you what? A fiberglass cast. So let's look at the properties of the plaster cast, which is contains the POP, which is the plaster of Paris. So we have it being very heavy and it's not expensive, but it provides excellent molding and it's not water resistant, and then may take a longer period to dry, which is from 24 hours to 72 hours. And there is an increased risk for thermal burns because in application of this material it exogenously produces heat, and which can risk the individual whose body part or structure that the cast is going to be applied on paints. So let's look at the fiberglass cast. The properties is just the opposite or mostly the opposite of the plaster cast. So they are light in weight, they are strong, they are durable, and they dry quicker within 30 minutes as compared to the plaster cast. So some are waterproof in respond or corresponding to the plaster cast, which is not water resistant. These two properties are going to serve as a good point to note during the cast care. Then it allows for better x-ray visualization. So it's very light in weight, so that gives it the quality of it being able to be easily visualized under x-ray. And then the last property is that there is minimal thermal burns when it comes to fiberglass cast. So let's look at the pre-application assessment. What you need to look out for. before application of the cast. And this is where we are supposed to take note of, because this presentation is technically based on you being oriented to the topic itself, which is immobilization device. You get a little concept over there. And now the most part is we are focusing on the examination part, which has to do with the cast care and the assessment. So we start with our first point. So what we need to do is assessment, the hard part. So assessment always comes first. So you assess the patient's general health, presenting signs and symptoms, emotional status, understanding of the need for the device, and condition of the body part to be immobilized. So first of all, assess the person, especially the emotional status, the person's readiness to actually undergo this procedure to have this device fixed for immobilization purposes, and then the state of the area this device is going to be applied. Another assessment to do is the skin and then neurovascular status, which includes the degree and location of swelling, bruising, and skin abrasion, which is just a build-up point from the first one, where you are supposed to look at the condition of the body part to be immobilized. And the third point also follows up, which after looking at the area or the condition where the cast is supposed to be applied, you now do your final judgment. So when there is lacerations and abrasions, you treat and care for those parts before the device is applied. And in a case where it's a serious one, when the device is applied, they create a window to expose where the wound is so that dressing can take place frequently. And also, if it's more severe, they go for other methods like traction. Now the next thing is provide tetanus booster. So in case there is an abrasion laceration, it predisposes the individual to Clostridium tetani, which is the causative organism for tetanus. So a tetanus booster is injected actually to counteract the organism where necessary. So look at the post. So after application of this device, what should you look out for? So you monitor for neurovascular status, which is peripheral circulation, capillary refill, motion and sensation, movements of the area, and then sensation to stimulus as well should be monitored at least every hour for the first 24 hours and every 1 to 4 hours thereafter. Then you have to assess for the neurovascular compromise, which is the CSPs, which is related to the compartment syndrome. First thing to look out for is the pain, and then the pain is always severe and not proportionate to what the normal pain has to be, normal pain threshold of a casted body part. So we have hypothermia, which has to do with the body's temperature not being able to adjust or maintain its core regulatory abilities. So meaning at this point in time, if the environment is cold, that body part which is being casted will not be able to actually adjust and maintain a normal core body temperature. When the environment is hot, at that point, that casted aspect of the body will not be able to adjust and regulate a core body temperature. You have pallor, pulselessness, then paresthesia, and paralysis. These are the 6Ps you have to assess for, and we'll get there and we'll talk much about it. So you need to elevate the extremities above the level of the heart to enhance arterial perfusion and control edema. Then you manage pain with analgesic agent, elevation, ice or cold pack as prescribed based on hospital protocols. So you monitor for signs of infection, which has to do with unpleasant odor, purulent drainage, and fever. Then one thing to also look out for is a freshly made cast which is wet should not be handled by the fingertips, but should be handled by palm. in order to prevent indentation. So wet plaster cast should be handled by palm to prevent indentations. Then cast should be exposed to circulating air to allow it to dry. So you are not supposed to cover it, you have to allow air around to enable it to dry on a firm and smooth surface. Then usually after cast is done, especially the plaster cast, it comes with the edges being a bit rough, and then they end up irritating the skin because of how pricky it looks. So it's either they smooth those areas out, or you do petaling, which is we use the moleskin over there, which is more a soft adhesive material that is inserted inside outside of the edges of the cast in order to prevent these rough edges from gaining access or rubbing against the skin, and then that was preventing irritation. So let's look at what you do through education of the patient. So first, you educate patient and family on cast care, signs and symptoms of complication like compartment syndrome, as we said earlier, importance of follow-up appointments for continuity of care. Then you have to encourage patients to move all fingers and toes hourly when awake to stimulate circulation. Yeah, so you have to always do that to allow circulation to take place. Emphasize the importance of reporting unrelieved pain or increasing analgesic requirement immediately, which can be a sign of a complication, which is compartment syndrome. Encourage range of motion exercises for the unaffected limb. So it's very important that the other limb that isn't affected, make sure you exercise it frequently. If you're going through exercises frequently in order to make it active and improve circulation as well around that area. Then you have to elevate the casted limb also to reduce edema. We talked about that earlier. Then you have to keep the cast dry and clean. And this is related to the plaster cast because it's not water resistant. To prevent maceration, which is skin breakdown, then we have skin irritation, infection, and weakening of the cast material. And in case you have to bath, especially in relating to the plaster cast, you use a plastic bag or a cast cover to cover the casted area before bathing. And then the last point is you should avoid inserting objects into the cast to prevent skin injury, because that place is covered. An injury can occur, you might not feel it, and then it will be there and then predispose you to infection, which will be a complication that will be detected not early but later part. So look at the complication of cast and then certain action that can be taken. So we have so many complications like infection, we have joint stiffness, and then we have cast syndrome, etc. But this time round we are going to discuss only two, and then the rest will be in the follow-up presentations. So we have the complications as follow. We have compartment syndrome, which we talk about frequently throughout the presentation. So this occurs when there is an increased pressure within the casted limb, which compromises blood flow, leading to tissue ischemia and possible permanent damage. So what do you do? So first of all, to know that there is a complication as compartment syndrome, we first do the 6P's assessment, which are the pain, pallor, pulselessness, paresthesia, paralysis, poikilothermia, and then you report to the physician. Elevation of the limb is also needed, and then you prepare the cast for loosening, because at this point in time it's restricting blood flow. And the next thing you do is you monitor for neurovascular status continuously. That has to do with the circulation, sensation, and motion. Then you prepare patients for possible emergency fasciotomy, the surgical procedure that is trying to or aim at or possibly aiming at relieving the increased pressure in the casted limb. The next complication we'll look at is the disuse syndrome, which is muscle atrophy. So that's also known as muscle wasting, a weakness resulting from prolonged inactivity because the limb is casted. Actually, it won't be used much in activity, especially when you fail to do the needed exercises prescribed for you. So what do? You teach isometric exercise, then encourage early muscle contraction while awake, promote mobility within prescribed limits, and then you look at nutritional support to help in muscle recovery. Technically, your vitamin C's and then your proteins, all needed diet, and this is done with collaboration with the nutritionist as well. So look at the trial questions to give us a recap. So a nurse is caring for a patient with a newly applied plaster of Paris. That's the plaster cast. How should a nurse handle the wet cast during the first 24 hours? So handle cast only with the palm of the hand, which we stated above should be the main answer. Then we have used the fingertips to ensure a firm grip. We don't do that. It's going to create indentations over there, and that's not what we want. Cover the cast with heavy blanket to retain heat for drying. We said you are not supposed to cover. You are supposed to allow circulating air aid in drying the cast. Keep limb in a dependent downward position. We encourage the limb should be elevated to decrease edema. So the answer is A with the rationale below. So let's look at the next question. The nurse's role in post-cast application care is patient education, which includes instructing the patient to do what? So remove the cast if swelling. That is not a duty of the patient to do. Apply oil at the cast edges. No, we don't apply oil. When the place is irritating, you go for the moleskin, which is pecalin. Then C, perform prescribed exercises. Yes, isometric exercises are very needed to allow circulation as well as to prevent disuse syndrome. Limit liquid intake. For liquid is very vital because our body is composed of a higher percentage of water, so you won't be limiting fluid. So the answer is C with few rationale hanging over there. So next question. So a complication which is most associated with a tight plaster cast. You have osteoporosis, no. Compartment syndrome, yes. Cast syndrome, no. Muscle atrophy, no. So here, the three main complications associated with plaster cast is the compartment syndrome, cast syndrome, and then muscle atrophy. But here, looking at the definition above, compartment syndrome takes the weight. So the answer is B. And then next question. And the last, with question 4. Which complication result from prolonged immobilization leading to muscle wasting? Pressure ulcers? No. Disuse syndrome? Yes, which is the same as muscle atrophy. Compartment syndrome? No, which has to do with the 6 P's. Then we have infection. No, which we have to look at the fever and the drainage. So the correct answer is B. Thank you for your time, and then until we meet next time in the next presentation. Actually, the aim here is to get oriented with the topic. We know there are lots more into the introduction of cast, introduction of immobilization device, but here we are more focused on some particular parts, more of a summary, and then most of them will be taught in your class during your lectures. Thank you very much for your time.